All right, nerds, I got another case for you which I found very interesting and I think is something important to add to your armamentarium of knowledge. I always make fun of everyone else's names on this thing, so I might as well make fun of my own. This was my case. My first name is Patrick, my last name is Bruss. My middle initial is M. I'll let you guess what that stands for. My mom's side of the family was Irish. My dad's side of the family was German. The name Patrick means nobleman, and it was popular in the Irish because of St. Patrick's. And Bruss is German, and it's short for ambrosia, which was the food of the gods, which means like immortal. And the other meaning was like something that's abrasive or hard, like a whetstone that you can sharpen something against. So my name means a immortal nobleman who's abrasive. I've never seen a more fitting name in my entire life. Like, I am the whetstone with which you sharpen your mind against. Like, I'm all abrasive. I'm Irish. I'm German. My parents knocked it out of the park. Good job, Mom and Dad. All right, here's the case. Patient is a 68-year-old male who presents to the ED for evaluation of near syncopal episode. He reports feeling dizzy Saturday, but denies loss of consciousness. The patient states that he was able to sit himself down to the ground without falling. He denies headache, diarrhea, or vomiting. Today he endorses he doesn't have any symptoms. Good job. All right, so pre-test probability, he came in for a near syncopal episode and currently has no symptoms. Let's progress to the electrocardiogram. Here's his previous one. Again, as an exercise, I recommend you pause, go through, think about what your findings are and what your interpretation is. And remember, the value of the EKG depends on pre-test probability. This is just a previous EKG to establish a baseline. All right, here's what Patrick sees. Rhythm strip. There we go. Rhythm strip. We got 1P for every QRS. The rate is normal. We have sinus. We're done. Let's move on. Before we move on, let's note, there are some abnormalities of the atrium, including this large Denot's atrium we can see, or P wave in 2-3 and AVF, which can be suggestive of right atrial abnormalities. And we also see this biphasic P wave in V1, not so much in V2. That can be associated with the left atrial abnormality. The access is up in AVF and up in 1, so it's a normal access. I do see what looks like a fractured QRS in 2-3 and AVF, or this slurring of the S wave here, which sometimes is referred to as a reverse delta and can be associated with mitral valve prolapse. For the intervals, I do see a QRS that is greater than 120, and we have an RR prime in the precordial leads consistent with a complete right bundle branch block. By the way, when we see this RR prime, what we're seeing is the anterior fascicles on the left side. Like when the right bundle is blocked, we're seeing electricity go through the left bundle, and that splits off into the anterior and posterior fascicle. And this highlights, why the anterior fascicle is more easily blocked, because it carries such less voltage than the posterior fascicle does. And again, we see this abnormal QRS here. We have an R prime, again, which is consistent with structural fracturing QRS concerning for structural heart disease. I don't see prolongation of the QTC, but again, I would refer to the machine for that. For repolarization abnormalities, I'm not seeing much J-point deviation. Remember, for these right bundle branch blocks, always keep in mind where the QRS begins and ends, because people often overcall or undercall J-point deviation because they lose sight of that. Like up here, you might be tempted to call this J-point depression, but that's still within the QRS. Same thing here. Where's that J-point depression? Well, no, because the QRS ends there. And same thing here. Oh, that looks like ST elevation. Well, no, it's not, because the QRS ends there. Okay. Same thing. I'm not seeing much J-point deviation in these leads, not in AVR, AVL, or AVF. I do see these inversions in 3 and AVF, which are non-specific. Again, remember, in the precordial leads, I do see T-wave inversions in the precordial leads, which is okay in a right bundle branch as long as it's slight, right? Like this inversion is like nowhere near the amplitude of this QRS. And again, over here in the lateral leads, I'm not seeing much J-point deviation. I do see this fraction of QRS. I do see these non-specific T-waves here, which in a different setting, if they were in the precordial leads, I'd be concerned for hypokalemia or reverse Wellens. So overall, my interpretation is sinus rhythm with signs of structural heart disease, complete right bundle branch block, non-specific ST wave abnormalities, like nothing conclusive. All right, here's the first EKG we have when he came into the emergency room. Again, pause and go over it. Overall, I'm not seeing much changes from before. I do see 1P for every QRS. I do see this one lone PVC, which I'm not too concerned about. Same thing, like the access is normal. We have these same inversions in the in 3 and AVF, which look kind of worse than before, right? Like this inversion was kind of worse than before. I'm still not seeing much J-point deviation. I don't see any QT prolongation. Same thing, we have this RR prime here. Same issues, we have these abnormal T waves in V4, 5, and 6, which are worse than before. But again, remember the pretest probability came in for like a near syncopal episode. So my overall interpretation for this is similar to before: sinus rhythm with structural heart disease, a PVC, nonspecific repolarization abnormalities, all of which is non-diagnostic. Again, this guy's not complaining of any chest pain or shortness of breath. It was one near syncopal episode, and he has no symptoms now. So overall, not too concerning. So we're working him up in the emergency room, and a little while later, he says, I feel like I'm going to pass out again, so we got another EKG. Same thing, pause, go through it, think about what your findings, interpretation is. Here's what Patrick sees. So here's a PVC, PQRST, and another PVC, PQRST, another PVC. So we got bigeminy, right? We have one normal beat and one BVC, bigeminy. Overall, the axis is still, we're getting more rightish, but it's still normal. Again, I don't see prolongation of the the QTC. The QRS is consistent with a complete right bundle branch block. We have these ST wave abnormalities, which are not progressing, okay? So the main thing for here is when we get to this point, when you're having frequent PVCs, either bigeminy or trigeminy, you have to distinguish between the heart rate versus the pulse, okay? The heart rate is something a machine gives you. It's a number the machine gives you by counting the electrical beats per minute, okay? A pulse, I always forget the E, is something that you have to feel, okay? No machine can give you this. Like, you have to feel. You have to actually touch the patient to figure it out. So let's go through, okay? Let's see what the heart rate is. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 times 6 is 66, so the heart rate is 66, okay? But when we go and actually touch the patient and feel the pulse, here's what we see. No pulse, pulse. 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 No pulse. So the pulse is only 1, 2, 3, 4, 5 times 6, 35. So the pulse is only 35, right? So this is a tricky thing and an easy thing to miss. Everyone's like, oh, the heart rate is normal, the heart rate's 77, the heart rate's 80. Well, yeah, but the pulse is half of that. The pulse is only 40, and you have to go feel it. Like, you can only feel the pulse here, okay? So that's what this guy's problem was pseudobradycardia. And again, also, he was admitted, saw cardiology, they did all their things, and his echo did show mild to moderate mitral valve regurgitation, which was indicative from that reverse delta that we saw. And again, I'm not making this up, it's called pseudobradycardia. It's a frequent occurrence since PVCs are associated with an inadequate filling pressure with a result low pulse pressure that may not be detected by these non-invasive methods, making EKG or auscultation the only approach to accurately assess the heart rate in these patients. And that's what I'm talking about. Like, you have to actually go feel the pulse in these patients. Same thing, more data, which you can look up and read at your leisure. PVCs can interrupt peripheral pulsations, and thus pseudobradycardia is the result. And here's what they're highlighting. Like, here's the issue. Like, down here, like when these have these normal beats, those correspond with like filling pressures and everything. But we have this PVC. Sometimes it's not enough to have a corresponding pulse with it, and you get pseudobradycardia and you get symptomatic, and that needs to be addressed. And again, here's the literature. For the reverse delta, is it like the most accurate finding in the world? No, it's just something to know about. And this is what they're highlighting. It's that downsloping of the S wave, most often seen in 2-3 AVF, consistent with a reverse delta, because the delta is the front upsloping from WPW. Do not confuse this with the crochetage sign, which again is a fraction in QRS, but it's mostly like up within. It's not like down at the base here. Again, is it 100% no? But I mean, it can help tip you off to issues and stuff, more reverse delta pictures. That's all I got for this one. Okay, the short of the story for this one was with PVCs, you have to differentiate between the heart rate and the pulse is only something that you can feel. That's all I got. I hope you found it enjoyable. Done.